الحياة التي يعيشها الشعب الكويتي خاصة تجعل الإصابة بضغط الدم وأمراض القلب والشرايين من أكبر مخاوفه التي يخشاها. هذه الأمراض بدأت تغزو صحة الإنسان بشكل خطير. لماذا؟ وكيف هو السبيل للحد من انتشارها؟ سنعرف ذلك مع استشاري القلب وعمليات القسطرة الانترفنشنال كارديولوجيست الدكتور إبراهيم Al Rashdan. فليتفضل مشكورا.
بسم الله الرحمن الرحيم. First of all, I would like to congratulate you and thank you, especially Noura Shargawi and Mariam Mashour and your colleagues. You guys have done a wonderful job. I'm really proud. The way you conducted this was fantastic. The other thing that I'm really proud of, and Noura has been methodical, and she sent me emails of how to behave. You see, so she told me what is the objective. You don't talk nonsense. You talk to us whatever we ask you to talk to us about. So I try to follow your orders, Noura. Basically, I did not want to make this lecture a lecture about cardiology, hypertension, and coronary artery disease. I guess you guys are experts right now. So we will touch on some aspects of this disease in Kuwait, and specifically what is wrong with us in Kuwait. Okay? Bismillah. Okay. So this is Kuwait. You guys know Kuwait Towers. I show this Kuwait Towers in every presentation I do outside, just so that people know where we are. And the statistics in Kuwait, as you know, we have a population of around 3.5 million, and we have around 1 million Kuwaitis. A little bit more females. So females are more than males in Kuwait. You have around 2/3 non-Kuwaitis in your country. This number is a little bit worse in other countries in the Gulf. For example, Emirates, around maybe 90% non-nationals. So although this is a little bit reverse, but we're better than other countries in the region. Few numbers are very important to remember. What is our gross national income? What is the life expectancy in Kuwait? And this is 77 years and 79 years. Okay, this is very important. So life expectancy is quite good, but healthy life expectancy is 10 years less. So a lot of people tell you, doctor, why should I worry? Why should I stop smoking? Why should I treat my hypertension? I'm going to die when God decided the day I'm going to die, I'm going to die. Why should I, treat myself? You tell them, okay, you could die on the day that you were supposed to die, but you're going to die when you were sick for 10 years. These are what the data is telling us, okay? So we live a healthy life 10 years shorter than our life expectancy. One of the other things that I wanted to show here is the total expenditure on health, and this is 2.2% of our gross national product. Now, if I ask you how much the Ministry of Health provides yearly for the health benefits in Kuwait, how much are we paying from our budget per year? Anybody knows?
1.2 billion.
Okay, so 1.2 billion, and we think this is too much. If you look at countries around the world, for example, we had a project with Harvard, and the only hospitals in Boston, that's not Massachusetts, that's only Boston, few hospitals, they have double the budget in Kuwait. Okay, 6 hospitals in Harvard, they have double the budget in Kuwait for health. So although we're spending a lot of money, what is the majority of the 1 billion, 1.2 billion? Majority of that? Salaries. So majority of the expenditure that we have is salary. So we're not spending a lot of money on health. And if you say, is our health system worthy of 1 billion KD per year? I guess you would say no. Okay. Enough politics. So diseases today, in the past we had diseases were communicable diseases. People died of malaria, people died of TB, people died of lots of these things, but now there has been a shift to what we call the non-communicable disease. And the leader in the non-communicable disease is cardiovascular disease. It's more than cancer, it's more than diabetes, and it's certainly more than car accidents. Okay, so we are killing more people as a result of coronary artery disease and cardiovascular disease than motor accidents. And so we're having a lot of people die at the end of the year as a result of this disease. So this disease is definitely worth a lot of attention, a lot of care. Now, some of you might have seen this slide. This is a very important slide. So why is it that we are having a lot of increase in the cardiovascular disease? And the reason is basically urbanization. People are moving to cities, and when you move to cities, if you live in an urban, in a rural situation, you will move more, you will eat less, and your work would have a lot of activity. However, here you have less physical activity. Why? Because you use cars, you use escalators, you use elevators. You have high energy consumption. Kuwaitis are used to go to restaurants, you know, cider station, you go to hamburgers, you go to a lot of these fast food. So this is a common social aspect of living in Kuwait. Fat consumption is high and psychosocial stress. As a matter of fact, many of you know that I work in the chest hospital. I do also work in a private setup. And a lot of people don't come to the chest hospital for a simple reason. Now, in the private setup, what we see, most of the patients who come to us really complaining of chest pain and chest tightness, they have nothing. What's wrong with them? Stress. People are stressed in Kuwait. Why? I don't know. They're extremely stressed. Young people, young girls, young boys, stressed, they have pains as a matter of psychosocial stress, and there's somatization, so they feel the pain but they don't have any problems. All these things will increase your obesity. This will cause dyslipidemia, dysglycemia, and hypertension. Now, these are pictures of Kuwait not too long ago, just a few decades ago. And if you look at any pictures, go to the black and white pictures of Kuwait, you will see the people who are really thin. And I would like to draw your attention to this guy, really muscled up, no fat. You look at some of the guys there, all ripped, you know, six packs. Look at the guy there, he has deltoids ripped. You don't see these things anymore. You know, people are with big bellies and big fat stomach, and they don't have these ripped muscles. These are our not ancestors, but these are our maybe parents or grandparents. So what's wrong with us in Kuwait? And I'm glad that we did have a work that was done not too long ago. We did evaluation, a population survey. Now, mind you, if we live in a hospital setup and we survey people who come to us in the hospitals, we are picking the tip of the iceberg. We need to go to the population, to the nation, to see what's the problem. And this was one thing we did, and I was a proud member of this team, especially for the cardiovascular part. It was done with WHO, Ministry of Health, and I was part of that. Okay. So what was the percentage of hypertension according to this survey in Kuwait? This was done in 2006, 2007. 24. So 1/4 of the population in Kuwait has hypertension. 1/4. Okay. So if you have, and this was only for Kuwaitis. This survey was only for Kuwaitis. So 1/4, and the survey was for patients between 18 and 65. So this is active. It was not the 70s and the 80s, but this was 18 and 65. 1/4 of these guys have hypertension. That's a huge number of population with hypertension. Now you know that why do we need to know about hypertension? Hypertension increases the risk as the more the systolic blood pressure, the risk, this is the relative risk with regards to the normal population. For systole and for the diastole, your risk could double, quadruple, or five-folds higher if you have a blood pressure systolic or diastolic as high as you can see in these diagrams. So the reason we treat hypertension is not to decrease the numbers. We don't care about the numbers. We care about the result. What happens at the end of the day with hypertension? Again, the one thing that I would like to draw attention, maybe some of you have seen these. These are coming from important trials in the past with hundreds of thousands of people. Hypertension has to do with stroke more than heart disease. So the more the high blood pressure, the higher the chance of stroke compared to coronary artery disease. So if you treat hypertension very well, you will decrease the chance of stroke, which is a very important burden of disease. One thing that I would like to also emphasize extremely and very strongly is that when you say hypertension, and I'm saying this as a result of my experience in Kuwait, you know, people come to me and they have a blood pressure of 145 over 90. You know, it's a little high. And he's worried, doctor, give me some medicine that gets it down. I say, fine. But he smokes 2 packs a day. I say, wait a second. You know, why do we need to drop it from 140 to 145 to 135? You're still smoking. Because hypertension is only one factor. And as you can see, the more you add factors, systolic pressures, cholesterol, HDL, low HDL, diabetes, cigarette, and diabetes, every aspect you add would increase your chance of developing coronary artery disease. So hypertension alone does not mean anything. It's a full risk profile. And I'm glad, who reminded me to talk about this campaign we're doing tomorrow? Yes, Maryam Al-Asfour. So the organizers of this conference are doing a campaign tomorrow for evaluation of cardiac risk, and this is going to be a great project. And I wish to see the results of the campaign. So register everything. So please contribute with the campaign to get some results. And I guess you could get something like this, something similar to this, and I would be pleased to work with you. So if we talk about what happens in Kuwait, and these are the numbers, maybe the colors don't show very well. Why do we have all these problems? And I think one of the main things in Kuwait is physical activity. This thing we have done evaluation of the physical activity using something called GPAC. GPAC is Global Physical Activity Questionnaire, very scientific measure of physical activity. So how active is our nation? How active is our people? And unfortunately, it is not good. It's not good. It's really very bad. So the activity level, how do the GPAC is a tool utilized or made by WHO. It stands for Global Physical Activity Questionnaire. So how do they do it? 2 things. Physical activity at work, physical activity at leisure. And work means you work with your hands. Now how many Kuwaitis go to work with their hands? They work. Most of them go work on the desk. They do nothing. They finish their work at 9:30 and start drinking coffee and reading newspapers. Unfortunately, that's true. Agree with me, Dr. Ahmed? Okay, so this is the problem. So at work, this is the science behind what I'm saying. At work, more than 80% are no or very light activity. Like teachers. Teachers tell you we're very active. With all due respect, and they're just standing like what I'm doing here. That's not activity. This is not considered activity, okay? Or ladies at work doing some dishwashing or cooking, that's not considered activity. Activity means real activity. You know, working with your hand, digging, wells or building things. So that's what we have. It's very bad. Physical activity in the leisure time. So you say, no, we don't work at work, we don't do physical work, but we do physical activity at leisure. The weekends, we go to the gym. Or we go الممشى عندنا بالسرة ولا بسلوى ولا بمشرف ولا ما أدري وين. Okay? صح, we see a lot of people walking, but these numbers are very small for the population size. It's actually very small. So the leisure activities also 80% are inactive. So in total, if we look at the total activity is leisure and work. 80.3% of your nation females are, this is at work and this is at leisure, but basically at around 80% are totally inactive. What is the name of totally inactive? The Americans call them? No, something else. Americans call them couch potatoes. So we are couch potatoes, unfortunately. Moderate activity, and this is vigorous activity, is very little. Now, you have no activity that causes what? Causes obesity. This is truly what's happened, in Kuwait. So this is a survey I have done, and I published this data about prevalence of overweight according to age group. So as I said, this evaluation was between 18 to 65. So these are the numbers that I pumped out. So overweight, as you can go, so you hit 75 to 78% are overweight once you are 25 years old. That's amazing. Once you hit the 55 years old, look at the females there. 98% are overweight. 98%. That is staggering numbers. Now we looked at obesity. As you know, overweight is BMI more than 25. And if you want to say, well, overweight is a little fine, you know, you don't have to be very thin and nice. What about obesity? Obesity, look at obesity. So this is also very staggering. You know, you go to age 35, you have almost 50% of the women are obese, BMI more than 30. You hit the 55 level, you have three quarters of your women, your mothers and sisters have obesity. That's a huge problem. And what we have done also is I looked at the metabolic syndrome. Who knows what's metabolic syndrome? So there's no question here. I'm not trying to be your doctor, your friend today, okay? Friend, your colleague. Metabolic syndrome is what I think is what's going on wrong with Kuwait. Metabolic syndrome is little obesity, little hypertension, little hyperglycemia or hypercholesterolemia, so little bit of everything. Hypertension is a little bit there, blood pressure is a little bit, waist circumference is a little high, weight is a little high, cholesterol is a little high, sugar is a little high. You're not diabetic, but your sugar is a little high. This is called metabolic syndrome without getting into the details of the definition. If you want the details of the definition, you can go and look it up today, and I'm pretty sure you can do that. Metabolic syndrome in Kuwait is staggering. It's unbelievable. 64 versus 71% in this age group. 50%, 57%. It's a huge problem. As long as you go with your age, your risks increase. And why? Because you tend to live the bad habits in Kuwait. So, Kuwaitis are the world leaders. We are the world leaders, right? And obesity. I was really, this is an exercise I've done, and I looked at the results of obesity in a study that has looked across the globe. This was the only study that it was called the Inter-Heart study. It was looking across the globe, you know, Europe, China, South Asia, Arabs, Latin America, and Black Africans, you know. So, and this is Kuwait, our study. You know, overweight, we are the leaders. You see that? We are the leaders. Obesity, we are the leaders. So we are the leaders at least in one thing. We should be happy. Okay. So how to detect and treat hypertension? You tell me, Dr. Ibrahim. Okay, so how do we detect and treat hypertension? And lots of my students, you know, when it comes to hypertension, they would like to think about what? Who can tell me? What do they think about? Sorry? You can speak loud, Mr. Al-Azmi.
When I think about hypertension?
Sorry?
When you say hypertension, what I think about?
Yes.
Nephropathy.
Huh?
Nephropathy.
Sorry?
Nephropathy.
Nephropathy, yes. This is a medical student who is reading a lot. And he thinks about nephropathy. Now, somebody who reads a little bit more, what does he think about? Huh? Secondary hypertension, right? Or what are the best treatment? Or how do we treat? Or what is the mode of action of medicine? Fine, these are good questions. But let us go forward and I tell you what I mean, that the message is being lost. Detection used to be difficult. This was the method people used in the old days to detect pressure. This was 300 years ago. Very difficult. And I know this, you know the story of this guy. This guy is a young doctor who invented the stethoscope for detecting blood pressure. It's Korotkov. It's a Russian surgeon, 26 years old. He made a huge difference in determining how to measure blood pressure. Okay? However, detection now became easy as a result of that. Treatment is extremely easy. Extremely easy. Why? Because you have international and national guidelines from societies teaches you what to do. So basically, you start with lifestyle modification. Once the lifestyle modification is exercise, weight loss, and improving your dietary habits, and then you add medicine, and usually you add 2 medicine to improve the blood pressure. So that's not difficult. You know, treating blood pressure is not extremely difficult. It's easy. Medications are there. All you have to do is to prescribe it to the patient and follow them up. However, what is the difficulty? What is the difficulty with hypertension? The difficulty is you. You, because you become doctors, and I'm not saying you, I hope after this lecture you will become better you, but the you that is acting today as doctors are not doing a good job. Why? This is America, and this is we call awareness, treatment, and control. And this is the advice I give my colleagues on the campaign tomorrow, that you please check the blood pressure and ask the patient if he has, so you can come up with something like this. Okay? Now, mind you will see young patients. In America, the latest evaluation in Haynes, 27% had control. So if you have 100 hypertensive patients, only 1/4 of them was controlled. Okay? Only 1/2 was on medicine, and 1/4 was controlled. Okay? So I asked myself, what's going on in Kuwait? And I asked one of my colleagues who works in, she works in Yarmouk clinic. She's a family physician. She leads a lot of patients with hypertension. I asked her, what is the level of your control? And she said, you know, we have a control of around 50% or 40%. I said, this cannot be true, because Americans are doing 27, so here we're becoming the leaders of something else, which is, you know, doing a better job, which I doubt. I said, I doubt that, and I did a study myself, and I show you what we found. So this is a study I did to see what is the level of awareness on treatment control. Okay? So this is prevalence. So what is the prevalence at different age levels? So I told you that 24% of the population have hypertension. That was for the overall, 24 to 65. However, if we take this age group, 55 to 65, guess what is the prevalence? More than 50%. So if your age is 55, now I guess you're not 55, but you have somebody, or you know somebody that's 55, probably your fathers or your mothers or your grandfathers maybe, I don't know. And then their chance of having hypertension is 1 in 2. 1 in 2, if they are 55 and above. So if at that age level, this was the prevalence, this is the awareness. Awareness is almost half of the prevalence. This is true in Kuwait. So if you have hypertension, you are aware of it only 1/2 of the time. So if you have 10 patients with hypertension, you have 5 who are aware. Okay? The older you get, the awareness gets a little bit better, because people tend to examine it. What is the chance of you in Kuwait being on treatment? So if you have hypertension and you are aware of it, what is the chance of you taking the medicine? In America, if you are aware of your hypertension, chance of being on a treatment is 50%. In Kuwait, we are leaders. Actually, if you're aware, your chance of taking medicine is quite high. So if you're aware, you know you have high blood pressure, the chance of you taking a medicine, if I'm late, tell me please, If I'm late, Almoni, okay? But the chance of being on medicine is very high. However, what is the control? Control is very low. You know what I mean? So if you treat somebody with hypertension, you need to decrease their blood pressure. Okay? What happens? Why is this happening in Kuwait? A lot of people are taking medicine, but very few of them are controlled. Who can tell me why? نورا عندكم ميكروفون حق الناس ولا ما تبون؟ ما تبون استهجن؟ ما يبغوا يشتكون؟ Okay. That's it. Okay, I will answer. Why are not controlled? I call this doctor's inertia. Doctor's inertia means doctors have a patient, you give him medicine, and you don't want to change his medicine, his blood pressure is high. He comes to you next day. Why are we giving a lot of patients medicine? Because in our polyclinics, it's free medicine. free. So they come in, they have blood pressure, you give them a medicine, a prescription, they take medicine. Why you don't control it? Because the doctors are overburdened with patients. A doctor is seeing 30 or 40 patients per day in the polyclinic. So when a patient comes, the blood pressure is 150, the doctor is supposed to improve the medicine. He knows if he improves the medicine of this guy is going to come to him again next week. So instead of seeing 50 patients next clinic day, he's going to see 51 patients. So he says, you know what, you're fine. 150 is fine. يعني ماشي مع عمرك. Okay? This happens a lot, and this is a mistake because we're not doing a good job here. Now, one of the things that I've done, and I would like to draw your attention to this thing. So I call this is also from our publication, undetected, untreated, or uncontrolled hypertension. So if you have hypertension, you're either undetected, untreated, or uncontrolled in 89% of the time. So what are we doing? We're doing nothing. So your interest in knowing about secondary hypertension, about knowing the modes of the action of medicine, about how does it work, is not doing any good job. Why? Because you're doing that only for 10 out of 100 hypertensive patients. So that is what I would like you to take a message today, is that you take, this is the challenge. The challenge is not to know what medicine to give or to rule out secondary hypertension, is to treat patient properly with hypertension. So what do we have about specifics of coronary artery disease? Now we talked about hypertension, and in my view, the worst thing about hypertension is we're not treating it well. And it's simple, we're not caring for our patients. We don't care. We just give them the medicine, the hell with them. That's what happens. The patient comes to you, you don't care to bring it down because you know it's going to overburden you. So what is going on wrong with coronary artery disease in Kuwait? You have highest prevalence of diabetes compared to any nation. Diabetes rate is extremely high in Kuwait. We don't know what's going on. We don't know where we are going to end. Younger age of presentation. We see, you know, if you go to the Western world, you go to North America, you go to Europe, to see somebody who's 45 years old with coronary artery disease is considered amazing. In Kuwait, 35 years and 30 years and 28 years, we see these things commonly. So we are seeing a lot of, what is the one most common variable with young patients with coronary artery disease? One common in 100% of the patients. Sorry? Scream. That's the one. Smoking. So the one common across all the young people, everybody is smoking. If you are smoking, your chance of coming to the hospital at young age with coronary disease is quite high. So that is something I would like you to also remember. If we have time, I can tell you the story about smoking in young. Okay, if we have time, and if Nora allows me, we can talk to you about that later on. So we have more challenging disease because of diabetes. The arteries are very thin, very difficult to treat, and we have social influence. People don't want to have bypass surgery. They want to have stenting. They don't want to have go through cracked chest and things. So they force us to treat them with very aggressive stenting procedures. This is some of the data. I borrowed this from Dr. Mohammed Zbeid, who's done a Gulf race, which is a study across the Gulf regions. All the Gulf countries were involved in this study. And this gives you the baselines in Gulf race, which is people coming to hospitals with acute coronary syndrome. These are the numbers. The numbers are current smokers, 37%. 37% are current smokers. Shisha only 5%. Diabetes 41%. Hypertension 50%. Hyperlipidemia 30%. So you have a lot of problems with these risk factors included. One other aspect this was studied in the Gulf region is that it is 10 years younger. The GRACE, as you know, is an international study done on Caucasians. 65 or 66 years in the Gulf region, 50, 10 years earlier than the West. Now I have done a number of studies also, and I would show you some of the subsets. And the reason I'm showing this to show you the subset, this is a subset of PCI patients. Diabetes, when patients come to us at the hospital, is 64%. You show these numbers to any conference in the world, they will say what is going wrong with Kuwait. 64% of patient diabetes is unbelievable number. That's another publication also from our hospital. And here I'm showing also a diabetes rate 60%. So this is across a number of studies. It shows up 60, 65%, 70% of patients with coronary artery. These numbers anywhere in the world. In the worst society is 50%. So we are double of the worst societies in the West. That's a staggering and a very big number. Now, one of the things, this is one of the studies I did on treatment of difficult patients with coronary artery disease. They're supposed to go to surgery, but here we're treating them for the stenting procedure. Why are we doing that? Because CABG is refused by patients. Patients in Kuwait refuse CABG a lot of times, so that's the reason why we're doing high-risk procedures. So what can be done to hold and then decrease the alarming increase in CA? This is the question that Noura submitted to me about the objective. So what can we do? And you as students, we as professionals and societies to hold the increase, because it's still increasing, getting worse, or to decrease. What can we do? And I tell you, a lot of you will think of stenting, with thrombolytics, medicine, you know, all these fancy things, and the answer is not these fancy things. The answer is to have a national effort to decrease the cardiovascular disease burden. It goes across all the platforms, okay? Education, health, media, city designs, policymakers, lots of things across, not only in the policymakers in health, policymakers for the nation. And I will show you the results of some things that was done here. Now, I am proud to be a member of this اللجنة الوطنية الكويتية للنشاط البدني. I think this is a great committee. This was established in this faculty, and we have done a lot of work to establish that. Kuwait is the only nation that has joined this effort internationally, and I will show you what we have done. We have done this conference. This conference was done here. This was one of the major conferences on improvement of physical activity, because at the end of the day, physical activity makes a big shift. That is the main change of problems why we're getting a lot of coronary artery disease, because the genetics are the same. So urbanization, eating more, working less, exercising less, you know, this is causing all the problems. And this is under the patronage of His Highness the Crown Prince Sheikh Nawaf Al Ahmed is heading this activity, and we hope that this thing will see the light one day. Who are these guys? These guys were I was very proud to work with these guys. This guy, anybody knows about Agita Mondo? Agita Mondo is Portuguese. This guy lives in what South American country speaks Portuguese? Okay, so he's from Brazil. Brazil was again the same, has a lot of problems with obesity and coronary artery disease. He did Agita Mondo. Agita Mondo in Portuguese means I think dance, or you know, Portuguese like to dance. So he made this thing, and he was able to move the public. He goes to shopping malls, he goes to public, and you can see hundreds of thousands of people behind him. And he goes to certain, you know, in Rio de Janeiro, you know, the festival and all these things. He was able to motivate people to move. However, these two guys were here in 2009. Unfortunately, we had no visitors. I mean, we had just a number of people who were interested, but a lot of people were not joining us. But we had a great session. This guy is called William Haskell. William Haskell is Bill Haskell. You know, in America, William gets nicknamed Bill. Bill Haskell is a professor in Stanford. What was his task? His task was given by US to you want to tell me when am I supposed to stop, huh? 2 minutes? Okay, 2 minutes, fine. We're almost done. Bill Haskell was given a task by NIH and CDC to come up with a guideline, the national guideline for physical activity. So they gave him the budget, they gave him a lot of money, millions of dollars, to come up with one paper that tells people how to improve their lifestyle. Okay? Because they said doctors, they don't like to listen to nonsense. They like to listen to science. They are used to randomized trials. They are used to guidelines. They are used to reading papers. So please come up with something that you can convince doctors. That's what he has done with his colleagues. And they collected, let me show you some of his work, which is important. He did a paradigm shift. I mean, guys, the paradigm shift in this guideline of physical activity. So training was originally thought training is to improve performance. To train to improve performance. However, the paradigm was shifted to training or activity is to improve health. So you're doing training and doing physical activity to improve your health, not to improve your performance. Okay? So what they got 650 published papers, randomized trials versus observatory trials, and they came up with this. So if you do physical activity, you have strong evidence, very strong evidence. Physical activity lower the risk of early death, coronary heart disease and stroke, high blood pressure, and adverse lipid profile, type 2 diabetes, cancers, colon and breast. So you exercise, you have less chance of colon. You exercise, you have less chance of breast cancer. You exercise, you have less chance of disease. You have prevention of weight gain. So one thing, you do not exercise to reduce weight. If you think you exercise to reduce weight, you're mistaken. Okay? Because for you to reduce weight, this is what the science tells us today. Okay? So you can exercise. أنا أقول حق المرضى الإمكان أنت سوي رياضة هتحس إنك زين قبل لا تضعف. He feels better before he reduces his weight. Because to reduce weight, you have to reduce calorie intake. You cannot do it with exercise. And you have prevention of falls in elderly, depression and cognitive function. All these things improves in patients. Moderate evidence. There is a moderate evidence that functional ability, older adults, hip fractures, lung cancer, endometrial cancer. There is moderate risk of reduction, and this is amazing what exercise can do for you. Weight maintenance after weight loss, evidence was insufficient for anxiety disorders and prostate cancer. Sorry, Ahmed, exercise does not, or we don't have evidence to prove prostate cancer yet. Hopefully we'll get it in Kuwait one day. Physical activity guidelines for America. So what did they come up with from reviewing all these papers in America? And the papers were not only in America, it was across the globe. They say that all adults should avoid inactivity. Some activity is better than none, and adults who participate in any amount of physical activity gain some health benefits. So anything is better than nothing. But what is the beginning of the improvement is for substantial health benefits, as proven by science, adults should do at least 150 minutes of moderate intensity or 75 minutes of vigorous intensity activity each week. Okay, so this is what you tell your people, 150 minutes every week. What is that, 150 minutes? It's 30 minutes every day, 5 times a week. How could you divide it? I can tell you. This means that you could, I'm not going to go over these things, but basically you could divide the 150 minutes to as many times as you want. So you said 30 minutes per day. You want to make it 3 days, 50 minutes per day. You want to make it 1 day, it's 150 minutes. So you're a busy doctor, you have a private clinic, okay, and you don't have time, you can do the 150 minutes in 1 day. Is that allowed? Yes, that's allowed, but that will increase the chance of breaking your knees or having some tendinitis or things. However, what we know also, I'm not going to go over many of these details, what is the moderate activity? What is the moderate activity? A lot of people ask you, Doctor, شنو moderate activity? شنو moderate activity? Why you can't stamp السوق avenues I don't know where سوق شرق they stroll and look at the windows and things. Is that good? That's not good. Moderate activity is really, you're breathing heavily. So we say you cannot sing. If you can sing while you're doing that, you're not doing well. So you should not be able to sing. Okay? So that is moderate activity. Basically what I tell my patients is like walking 6 to 6.5 kilometers per hour. That's the speed is a moderate activity. One thing I would like to show you here is what is the 150 minutes? 150 minutes is here, okay, per week. This can decrease sorry, I'll go back. So you are allowed, according to the guidelines in America, the way to start your benefit is 150 minutes per week, and that will decrease the chance by this level. Now, if you do 300 minutes per week, that is where you max out in the benefit. After the 300, the marginal difference is very small. So we advise people, if we are talking about improvement of hypertension, coronary artery disease, dyslipidemia, diabetes, all these kinds of diseases, chronic diseases, is to be active and to do physical. So if we can go out today, what I would like to see is Ajita Kuwait. Ajita Kuwait means that you need to move, not dance, maybe you don't like dancing in Kuwait, but every move. And I can tell you, Nora, do I have 1 minute or 2 minutes, or I don't have? Done? Okay, fine, I'm fine. Well, thank you very much. I think what I wanted to say, I just had a few more stories to share with you, but I appreciate the next speaker. And if you have any questions, I will be more than pleased and happy to answer them. Please.
So when should a patient or a person say, oh, I should get my blood pressure checked? So is there a way of screening for hypertension, for example?
Screening your hypertension is measuring the blood pressure, and I think, as you can see, these are the simple things. Anybody who is age 20 should have at least one blood pressure check, and if it is normal, you can check it next year. So at least at age 20, you should have a blood pressure check. Everybody should have a blood pressure check. And as you can see, the blood pressure prevalence increases with age. So if you didn't have it today, as a matter of fact, the guidelines tells you 20 years you don't have blood pressure, you measure it 5 years later. Because the chance of increment is very low. Now once you're getting age 45, you should, if you don't have hypertension, you have to check it once a year. That is a very important question, because a lot of people come to you and they have hypertension and they say, doctor, I have hypertension only since yesterday. Why? Because yesterday the doctor measured it for me. But sir, how do you know you didn't have it for the last 5 years? He says, but I never had any problems, never had symptoms. But we know that hypertension does not cause symptoms, so you must have had it for maybe older or more than 5 years, but you didn't feel it until it was measured. Does that answer your question? Any other questions? Thank you very much. I have so many questions, but I'll ask them later.